Tēnā koutou katoa, nā mihi nui ki a koutou. Ko Jennifer Curtin toko ingoa. Kia ora, everyone. It gives me great pleasure to be welcoming Professor Sara Davies to our third Auckland Trade and Economic Policy School, ATAPS 2021. Sara is a professor at the School of Government and International Relations at Griffith University, and she's an adjunct associate professor at the Gender, Peace and Security Centre at Monash University. Sara is an international relations scholar with a specific focus on global health governance and the women, peace and security agenda. And it's these two topics and the intersection of them that are relevant for us here today. Her research career has been devoted to identifying the political conditions that deny humans access to civil, economic, and social human rights. And her research has focused on situations where humans face immense vulnerability, gender-based and sexual violence and conflict, forced displacement, and disease outbreaks and pandemics, such as COVID-19. Her regional expertise includes the Indo-Pacific, and how and when international governance has been able to engage with the rights-based needs of populations at risk, including women. Thank you, Sara, for joining us today. I look forward to hearing your talk.
Thank you so much for the invitation. I'm absolutely delighted to speak with you today, and I'm just going to now make sure that my slides are available for you to be able to see. Thank you for having me. So, first of all, I would like to acknowledge country. I'm in Yanjin, and I'd like to pay my respects to the traditional owners of the Turrbal and Jagera peoples, whose lands on which I am very fortunate to be able to talk to you from. And I would like to also acknowledge the beautiful trees and land upon which I am sitting here today, and acknowledge that this land was never ceded. So the outline of my presentation today is going to be looking at the three areas, and I apologize in advance for it sort of being quite a general overview, but what I'm hoping is that in our conversation, you can then, Jennifer, tease out little bits of information that you think that, you know, the audience might like to hear a little bit more about. So the first part of what I'd like to identify is what I and others have argued has been a gender-blind response to health emergencies. And we feel like, to a certain extent, a certain amount of frustration, I think is the polite word to put it, that this had been identified prior to the COVID-19 pandemic through other emergencies that we had seen in Ebola and Zika, and COVID-19 perhaps on a global scale exposed the very real gendered insecurities that those populations went through during those health emergencies, and they're still in some instances recovering from the consequences of those emergencies, as we're going to be seeing in the case of the COVID-19 pandemic. Then I'm going to look at the COVID-19 pandemic as possibly being an opportunity for progressive gender inclusion, particularly in the health emergency space, because of this collective experience that we've all had now of the consequences of gender-blind responses to health emergencies. And then I'm finally going to look at what are being suggested as the gender inclusive recovery priorities, and how are we progressing in that space. And I'm going to identify two areas in particular: vaccination and economic recovery, but there are many more that I think we could discuss as well. So first of all, in terms of terminology, I'm going to use, when I'm talking about gender, I'm referring to the World Health Organization definition here. But I would like to acknowledge, though, that this definition doesn't include non-binary genders. And in fact, I'm on a very small project at the moment that we're about to start to look into actually the experience of non-binary genders in particular locations and how they experience the COVID-19 pandemic. But what I'm trying to identify here, though, is, of course, when we're talking about exclusion or lack of inclusion, what is happening in health emergencies is this failure to recognize that populations experience these emergencies very differently, and they experience them differently because of these prior norms, behaviours and roles that determine access to services, that determine ability to make decisions in this crisis. And then there's also particular physical needs that may be specific to their environment that are not being met in these health emergencies. So prior experiences of deprivation and exclusion and marginalization are of course exacerbated in these situations. So I've put here at the bottom a reference to an article that myself and a colleague, Claire Wenham at LSE, wrote published earlier this year, where we looked at the World Health Organization and of course its member states' response to global health emergencies over the past 15 years. So the World Health Organization with its member states have been responsible for thinking about health emergency response through a particular legal instrument, which is called the International Health Regulations. And the purpose behind the International Health Regulations is that it advises states, but also World Health Organization, on how to respond to health emergencies. And from 2005, there was a particularly important revision to this regulation, which broadened the, if you like, definition of what constitutes a health emergency. Before 2005, it had been specific diseases. From 2005 forwards, there was the development of an algorithm, and it could apply to a broader category of what they call public health emergencies of international concern. And of course, that was what was so important about the COVID-19 pandemic, which was that we had, late January, Dr. Tedros convened what's called the International Health Regulations Emergency Committee to discuss whether or not this SARS-CoV-2 represented or presented a threat to public health at an international level. And as we know, that decision in the second meeting was made, and that was then quite important then for then leading to the identification of COVID-19 as a pandemic in March. And so what the International Health Regulations does is provides advice and expectations around how states and who should respond to these health emergencies. And the emergency committee convened for each outbreak, so this one for COVID, as well as ones that have been convened for swine flu was the first one, but then H1N1, and then we've also had subsequent health emergencies, as they set out recommendations on what states should be prioritizing, what they should be focusing on, what they need to be paying attention to during the course of the outbreak. They also, when these outbreaks are not occurring, there's what's called a health emergencies program, and they're setting out and assisting states with building what they call core capacity criteria. So making sure that states have legislation in place, risk communication procedures in place, as well as procedures at ports, borders, to assist with thinking about what types of trade and travel measures do you need to implement in the event of a health emergency. And then there's also what's called these national health security action plans. And they're also designed to be able to help states prepare for health emergencies, like what we call FEICs. And then there's also these joint evaluation exercises that they do to assess states' preparedness against the IHR capacity criteria. And what struck us after 15 years of this production is that there was really no gender mainstreaming advice. No gender mainstreaming advice in prevention. So what states need to be doing to think about populations most at risk and how do you address that? No advice around the healthcare workforce, and how are we going to think about the gender dimensions in this workforce, our dependence on this workforce in this situation? How are we going to make sure that they are present, able to participate, able to carry out their work, as well as perhaps their additional care burdens and duties? And there was also no real consistent advice around how we need to assess populations' ongoing healthcare needs, which may be related to gender. So what are we going to do around sexual and reproductive health, for example, in health emergencies? The only piece of advice that we could find across all of this was that states should strive to collect sex disaggregated data. And so what it meant that at the start of COVID-19, we had approximately 40 plus states that were consistently collecting sex disaggregated data in terms of infections of SARS-CoV-2 and then mortality. And so 2020 was really this large effort to try and just improve that, let alone also consider then the gendered implications of this pandemic on a global scale. And for those of us who've been studying health emergencies for some time, this was part of COVID-19 became for us a really important moment to indicate what we'd been saying and what those who've been affected by prior outbreaks, so in case of Zika in South America, in case of the Ebola hemorrhagic fever that had occurred in West Africa in 2014, as well as, you know, the Democratic Republic of Congo, is to identify that, you know, there are gendered experiences of health emergencies, and there's a persistent exclusion of those experiences, and a persistent exclusion of those experiences with consequences for recovery. And so we know in the case, and Julia Smith is a really great author who's written a lot about the examination of West Africa, and, you know, and she looked at a study of women in small enterprises and the impact that it had in terms of them being able to recover from that outbreak. So in the case of COVID-19, there was a lot of momentum and a lot of a lot of active engagement. And we know that the UN Women in particular, but also a whole range of important women-led civil society organizations were particularly championing the need for gender inclusion in the types of recommendations. But it wasn't until May 2020 that the International Health Regulations Emergency Committee raised concerns about the impact of the outbreak, specifically to gender-based violence and women's ability to access sexual and reproductive health services. It wasn't until September 2020 that WHO Director General held an audience with the Women in Global Health and Gendro to discuss whether or not there needs to be a specific inclusion of women's experiences and gendered experiences in health emergencies that need to be folded into their health emergencies program, and needs to go into the understanding now of any types of reviews that need to take place for the international health regulations. But I think it's also fair to say as well that what we've also seen to date is really no state identifying themselves as a leader, as a champion for gender and health emergency response in this space. And I think we see a lot of states talk about it, mention it at the World Health Assembly. It's always noted in a G20 statement, for example. But I think what we're lacking at the moment is this real imagination, but also just listening to experiences on the ground around what types of institutional process do we need to start to plan and adopt in the institutions that we already have and in the frameworks that we already have. At the moment, there's a lot of discussion about the creation of what's going to be called a pandemic treaty. And next week, there's going to be a special session at the World Health Assembly about this. And so we don't yet know what that's going to look like. But a lot of the process at the moment, like the IHR itself, is all under review. The health emergency program is under review. And so I think this is a really important moment right now for us to be thinking about individually as states, but also collectively perhaps, what lessons have we learned from the COVID-19 outbreak? What have we seen in terms of the way in which, for example, national health security action plans or advice from health emergency committees, where was vulnerability and experiences identified and when was it not? And how can we build into these structures that we already have inclusions and recognitions? I think it's fair to say that the UN Women and actually the UNFPA have done a lot of heavy lifting in this space, particularly in terms of feminist economic recovery, particularly in the area of sexual and reproductive services, as well as gender-based violence and access to social and welfare services. But I think their hard work that they've been doing needs to be folded into the health governance space. And I think it also needs to be folded into the foreign ministry engagement with the World Health Organization in this space. And this is where we need to really start to think creatively about how do we bring our ministries of foreign affairs, our Office for Women, and our health departments together to start thinking about what does gender inclusion look like in health emergencies, emergencies in general, and what can we also be doing in terms of prioritizing the scenario planning before health emergencies arise, and then also thinking about populations most at risk in its aftermath. So I think it's an opportunity that we haven't yet quite captured, but I think we can. Now I'm going to turn to the priority for COVID-19 pandemic in terms of what we're specifically seeing here. And I think for me, what's perhaps most concerning at the moment is that we're about, I think, at 3 different speeds right now. And I'm worried that we're not entirely conscious of what this means when we're thinking about recovery, and recovery for whom. So we're in a situation where we have high income countries, majority of whom are vaccinated, and the majority of whom, and I think this is crucial, have been vaccinated with an effective vaccine. They're going to require boosters, but for the most part, healthcare workers in particular, and most vulnerable populations, are relatively protected whilst they've got, that up-to-date vaccination. We have a number of then populations, particularly in low-income countries, that are struggling to gain access still to a vaccine, and they're going into a high amount of debt to be able to not just cover the vaccine, but also to cover all the consequences that are arising with the cost of being prepared for COVID-19, as well as maintaining the health services that their populations require. And remember, if we're thinking about burden of disease and mortality before COVID-19, we already know, of course, that low and middle income countries had health systems that were not necessarily at their strongest point, at the same time having to deal with high numbers sometimes of communicable diseases. So we've got a situation here where we've got added stress on environments that were already under added stress. And on top of that, we also have a situation in low and middle income countries where access to vaccines is very different. The type of vaccine populations are getting access to. We saw the United States and Australia and Japan and Canada and a lot of countries really step up in the second half of 2021 now, to try and start to accelerate access to those particular vaccines. But there's been a fair amount of lag. And so this catch up is going to take time. And on top of that, we're still trying to work out as well how COVAX is going to manage the distribution that's required, as well as the production of vaccine that is required. There's a lot of logistics that are still having to be worked out to really meet this volume of population that need to be vaccinated. And if they're not getting vaccinated, they're not going to be getting access to the global economy, and they're not going to be able to gain access without, presenting a health risk to their communities, but also to other communities. And so this inequity is going to have this long tail. And so we really need to be thinking about, what this means in terms of recovery for whom. And so what I want to identify here then is the immediate priority really is still vaccination. And in particular, I think what's important to note here as well, and to really pay attention to, is that we are starting to track some gender gaps here in vaccination. And I think that's something that CARE has identified, UN Women have started to identify, particularly UN Asia Pacific, because we do also have a problem where we're not really consistently tracking access to vaccinations that's sex disaggregated. So that sex disaggregated problem that we had with COVID infections and mortality is now presenting itself with vaccinations. And we know that the reasons why populations were being affected by COVID-19 during the lockdowns differently, for example, so, we know that women had higher care burdens. We know that marginalized communities were more reluctant to sort of leave homes and to step out during these highly securitized environments. Those issues are remaining for access to vaccination. So we really need to think then about how can we not just accelerate vaccination that is equitable, but accelerate a gender inclusive vaccination program to be real, and also to be prioritizing and establishing consistent data collection around COVID-19 vaccinations. Because this is vital for populations being able to re-enter civic economic spaces. We also have somewhat immediate but also long-term recovery priorities that really need to be sort of brought, and everyone's talking about this, but I think again it needs to be thought about in the context of those vaccination inequities, because what we're talking about here is food insecurity is rising, national debts are rising rapidly, and we have a situation where there's a high dependence on access to social welfare services and temporary payments And we know again that there were gender differences in who was able to access those payments. So people in the informal economic sector, for example, had much more difficulty being able to access those payments. And we know that there's also differences between women and women, rural and remote and urban, in terms of who was able to access those payments. We also know, again, thinking about the health emergency, what it includes, those frameworks, what it includes and what it doesn't include, that absence of inclusion of sexual and reproductive services, I do think resulted in the fact that we weren't prepared and we weren't thinking about this. And we have seen 2020 and 2021 create massive gaps in being able to access sexual and reproductive services during these periods of lockdown and militarized responses to COVID-19, which has resulted in not only unexpected pregnancies, but also a lot of discussions now that we're starting to see the sort of long tail where we're seeing across the region pockets of populations, particularly girls, but also boys, unable to return back to school, and boys going into more informal sector economy, which is precarious employment. And there's also anecdotal evidence coming out that girls are not able to return back to school due to added care work that they're having to take on at home, but also teenage pregnancy. So I think, again, the UN Women Feminist Recovery Plan here provides a really good guidance for the sorts of things that we could be thinking about at a regional level. And their emphasis there is on livelihoods, care, so really recognizing the impact that care roles and burdens had on re-entry into the post-COVID world, if you like, but also climate. And I think climate's an important one to think about in the context of health emergencies, and I'll come back to that in a moment. For me, one of the things that I've been looking at a lot in a project that I've been doing is looking at the impact of COVID-19 on women in small and medium enterprises. And we know that generally what's happening here is that they have been more likely, from the World Bank now we know, to have experienced a decline in their sales and profits due to a higher representation of women in consumer dependent sectors. They have had less opportunity to recover due to their high unpaid care burden. And they've had less access to public and financial support because they may not have, for example, access to bank accounts, digital services, clear sort of documentation that is required to access those types of loans, welfare services, support mechanisms that have been available to other populations. In a project that I've been looking at for the Australian Centre for International Agricultural Research, which I'll come to on my next slide, we're looking at the impact that that's had on vendors and farmers in 3 locations, and I'll come to that next. But I think what I would identify as the priority for the regional response right now is that we need to think through vaccination equity, because vaccination equity is the driver that is going to facilitate those access to jobs, relieving care burdens, and starting to address the future disasters that we are going to be facing in our region. There really is a need for us to acknowledge that health emergencies will continue due to rapid urbanisation, the desire to return to rapid travel and trade, as well as the fact that we are, having to adjust the way in which we produce food and consume food at a rapid rate, and that is exposing us more and more to zoonoses. So we really need to be gender inclusive here in our scenario planning. So we need to do more scenario planning, and we need to make sure that we are really thinking through the types of things that I talked about before. What are your minimal service programs for sexual and reproductive services? What is going to be done about small and medium businesses, informal sector workers, access to schooling and providing care relief? Include leadership. We're still tracking under 30% across all of our regions for women representation in COVID-19 response and recovery committees. Under 30%. In fact, the medium is around 24%, the latest data I've seen. So that's a big problem. So when you're at the table, you need to look around and see who's there and who's not there. We also need to be thinking through the gender inclusive One Health approach. And I think that's going to become important, as I've said before, because of the rise of dramatic climate-induced events, as well as the fact that our populations are going to be going through these migration and mobility shifts. So what this means then is that we need to be actually taking seriously the relationship between people working in the farming, animal health sectors with the populations and the communities working in the human health sectors. there is a real need actually for us to now think about when there's an African swine flu outbreak, or when there is a chicken, flu, we need to be avian influenza. We need to be thinking about, this may not be the one, the big, crossover event, but we need to be preparing populations for this, and we need to be taking it seriously, using it, if you like, as a moment to think about how we can prepare our populations. And so those are the things that are coming out of a research project that I've been doing with colleagues in Papua New Guinea, in Myanmar, and the Philippines. So I've been working with local women researchers, and we've been doing a lot of training over the last year, where we've been training basically to do fieldwork data collection, where we go to women farmers and we go to women vendors in these are very small environments, small villages, where we ask about what have been their experiences in terms of livelihood, access to food, access to income, and during these lockdown events, and what are their concerns around future planning? Are they able to be thinking about future planning due to the impact of COVID-19? And what we're finding here is that these women in these small sectors have actually a very good understanding of the impact that COVID-19 is having and the long-term consequences. They've had a high dependence on needing to be able to access funds, so short-term loans. They've also had an added cost to their work due to the need to protect themselves and their family from the infection. And we also are finding as well that these care burdens have been particularly high for them. So a lot of this isn't necessarily new to those of us in this area, but the next phase of our research is then trying to understand what types of interventions would make a difference based on conversations with these women around what do they identify as being the next steps for them to be able to recover. And we've deliberately started it at the local level rather than at the national level, because we want to know what their experiences and what their barriers are on a day-to-day basis. And if you'd like to learn more about that project, I've got a link to the project there. And we're also going to be hearing from these excellent researchers that we've got in these 3 locations. We're going to be talking about their work and their preliminary findings in early December. And we will be recording that event, and it will also be available on that website after the 15th of December. It will be there, but the live event will be on the 8th. So there's still a lot to be done in this recovery space. And I think that for me, what's most important is to think about the opportunities that COVID-19 pandemic presents for us to be prepared for the next outbreak, but also to be making sure that when we're thinking about recovery, we're taking into account the fact that we've got very differentiated experiences here. And so we need to be tailoring our responses according to the populations and what they're identifying as their needs to recover. Thank you.
Kia ora, thank you, Sarah. That's just covered off so many of the critical points that we'll be talking about at our conference. So it's great that you included climate, but also marginalised communities, because we know within New Zealand, it's been, even in a domestic context here, our Māori and Pacific communities have found access to the vaccine challenging. And so not only have we not necessarily had an explicit gender attentive responsive approach, if we think about it in terms of our Indigenous people and our more marginalised communities, the gender intersectionality dimensions also play out quite strongly. So that was wonderful. So I'm just going to pivot a little bit, because I think quite a few of your points speak to the topics associated with this conference, which is, the great trade reset. So we know that there's this interest in whether the World Trade Organization will be able to do its work differently, whether multilateralism will continue to be you know, an important lever for democratizing trade, perhaps, and accelerating trade agreements. Whereas the impulses from COVID and a pandemic like COVID are often quite nationalistic and quite internally focused. And, you know, when we get to big macro issues, we know quite often that gender becomes an aside. But I think when we think about gender inclusive trade, there's two levels which you've identified in your talk about that can impact how we think about the importance of this topic to trade and trade agreements and the economics of trade, which is it's at the macro level. It's kind of about how are we doing gender inclusivity when we're designing trade agreements and when we're thinking about them, when it's economy to economy or country to country. What happens to the representation of gender disaggregated data, to having women at the table who bring different perspectives to bear on the process? And then, of course, it seems much, and I'll put easier, to think about trade and trade agreements and the economics of trade as the impacts on different population groups. And really what your argument seems to be is that the disjunction between this, let's design something and now let's evaluate its impacts, could be ameliorated quite significantly by being gender responsive and mainstreaming gender much earlier on and gathering really solid disaggregated data. So given that, I just wondered how, just as a broad question, you know, how you think the process of, like, what you've learned by studying the WHO and its attempts to re-regulate itself in this regard could also then be applied to organizations that do different sorts of governance but are connected, like the WTO, or you know, you mentioned foreign affairs ministries when they're at tables considering the connections between trade and free trade and health and gender and equitable vaccine access, I suppose. Very long-winded.
No, that's great. I think it's about the way in which we think about the, okay, this is the long answer. I've been thinking a lot about this because one of the things that's been occurring to me in the World Health Organization space is a lot of arguments around the prioritization of health expertise and the way in which scientific and public health expertise is valued and seen as being the priority, right? Like, we don't have time, you know, we can't be everything to everyone. And I think what we're seeing now, and I think what WHO is hearing, is that you can exclude it. Okay, you can say the health emergencies program, with our budget, we've only got so many people to do the work. Okay, so if we have a person that we pull out to have as our gender person, for example, then something else more important, that's not said, but that's the subtext, right, is not getting done. And I think what COVID-19 pandemic has revealed is that if you don't have that, you really are going to then be running catch up afterwards. And it gets to a point where the success that you want to have is not going to be there, because you haven't started the conversation with just the question, is everyone who's going to benefit from this in the room, is everyone who's not going to benefit from this in the room? You know, and what can we do to talk about, to include, to think about what they are? And it's sometimes, and I think this is something that I think has happened, you know, in my ivory tower, you know, privileged kind of understanding of it. But I think it can be sometimes very hard to sort of be the person in the room who says, have we thought about, are we including, are we introducing this lens? And again, I can speak from the World Health Organization and the conversations that Claire and I had when we were writing that paper, is it really is this kind of, you know, event that happens where it's this budget pressure, deliver something, sound appealing to the majority of member states in the room, don't raise anything too controversial, and don't ask too much of states. There's always this sort of background going on. But I think what it means though is that, we're just not prepared for the event that comes. And so I think what's trying to be attempted now, very slowly, is this shift, because it's not just a shift from within the World Health Organization itself. It also requires this shift from member states as well. What they turn to the WTO, they turn to the when you ask people why do they turn to the WTO? Are they turning to the WTO to think about gender inclusive recovery? Perhaps not, but I think there's someone who needs to start asking, if they're not, why are they not? Because that's a good 50% of the population that you want to make sure are getting access here and are being talked about. And so again, I think and this is why I think there's a big push. We talk a lot about, there's great books, there's one behind me on data feminism, about the fact that we also do need to talk about the data that we have. And we do need to bring that up for all the problems that it will bring, and the issues and the risk of exclusion there as well. But I think, it's also, and that's why I'm pushing for small and medium informal sector to be included as well, because, there's a lot of economy and power that's operating in those spaces. And if we're not thinking about it, we're also, again, we're missing an important part of the recovery puzzle. So I think it's something that requires engagement with people who are working in their area of technical expertise. They feel comfortable in that space. And when you introduce this, it can sometimes be resistance, but it also can sometimes be, how am I going to actually do this? How can I include this on top of everything else I've got to do? So I think as well, it's about, having these conversations about, well, this is the benefit of doing a gendered audit. This is the benefit of bringing in that gendered expertise, of that sort of feminist methodology. This is what you bring. If you don't have it, this is the consequence.
So I suppose that just to bring it back then to domestic economies and so that's where you were kind of going at the end, like asking these questions in these environments. And given that you've looked at small and medium enterprises, and when we were the host of APEC 2021, New Zealand hosted APEC 2021, and as part of those meetings throughout the year there, and in the lead up to that, we had seen some work being done on gender inclusive trade, and a lot of this work at the high level talks about how do we think about doing that building that gender responsiveness and gender lens into the work that we do as bureaucrats, but also a really strong focus on women in the economy and how we can advance women's economic well-being. And so as part of that work, there's the Women in the Economy Forum, and that includes PEC ministers and APEC ministers and heads of delegations. And so this year it happened in September on Zoom, because everything was on Zoom for APEC this year. And there was a really strong statement about at the front about the challenges that COVID-19 was presenting to women in the economy. And then the rest of the statement noted the importance of the care work, where women work, the way in which health workers were really important, and also women's labour market participation, the prevalence for women to experience violence in different domains of their lives, for example. But what we didn't see, I don't think, in the statement is what you're talking about the importance of sort of, if you like, de-siloing and recognising that this pandemic isn't happening in this moment in time and that's all, that there will be long tail effects, but also there will be recurring events that present themselves in this kind of crisis disaster sort of way. So I wondered if you could draw out for us a little bit more about the lessons that we might learn, or the things that that economies in our region might be able to undertake that could be an incremental step towards shifting this process of siloing, or the process of being able to think longer term and do that scenario planning that incorporates the gender lens as a business as usual process?
So, as I said, we're in the middle phase of this project. So we've done the first phase of interviews, and we've done the first phase of thematic analysis of those interviews. So we did approximately 50 interviews divided between vendors and farmers across 3 of the countries, and we did it in different provinces in each country as well, to make sure that we accommodated different income levels, but also different farming and different markets. And if I had to sort of distill what I think, my team might think it differently, but I think if I had to distill what I think, it's an ongoing conversation amongst us at the moment. But I think the first one would be financing really did come out in ways that I thought was quite striking, actually. And I think this is, again, like APAC has quite, I remember APAC having a very strong position around financial inclusion. And I think what this requires is us to really think about what type of financing do small and medium enterprises need, particularly small enterprises need. What are the types of loan situations that we want to be, if you like, designing that if you like, enable growth and not, lock them into cycles of perpetual and growing debt. And this is one of the things that I'm a little bit concerned about, actually, after the COVID-19 experience, and what can we do to kind of arrest that and stop that from actually becoming a bigger problem. So I think financial inclusion at a very, in environments where the paperwork may not be there, where there may not be access to bank accounts. In the Philippines, that wasn't so much of a problem. Of course, we've had the coup impact in Myanmar, which is really, having a devastating effect on financial inclusion and empowerment there. But also in Papua New Guinea, we've got very different locations, very different, and a lot of them the populations talk about just that little bit of extra income to kind of invest, to grow, to begin. And I think that's something that we could be really thinking about across all 3 locations: affordable access to reliable digital infrastructure. That was just key. And it came up in terms of the care burden, which, again, I don't think we think about this as actually what it means, how much work, think about it. And I know as a parent, how much work went into trying to set up, the digital environment to facilitate learning, to facilitate, the access to the modules, so that even just for 10 minutes, you could run away, take a work call, run back, check that section of the house isn't on fire, and I think this is the sorts of, and you think about it then in an environment where, there is different levels of school modules that were being delivered, rapid needs to be able to access, just even sometimes in some locations, a mobile phone, just to be able to, to hear the teacher, or in the complete absence of that, and there was no online learning, there was no digital infrastructure there. And so what that meant when you had repeated cycles of lockdowns, and you're trying to still manage income, and you're trying to also care, and and you're also living in fear of what could happen if one of your family members gets sick with this infectious disease and it goes through the family, so I think that affordability to digital care was really important. But I also think, the other thing that's come out as this project for us as well is actually that impact of an emergency, and the degree to which I think there had perhaps that the accelerated work of local women's networks and just local community networks to assist, to provide information, risk communication, these are really important actually, because as we know with vaccine hesitancy, information is diffused now, it's not coming from one source. So what is your trusted, reliable source of information in a local environment where you may be getting very different pieces of information? The virus may not yet be there, and you're trying to work out, how do I navigate my community spaces? Which information do I trust about this outbreak? What do I need to do? There was conversations at times around, was the virus being transmitted through animals, through certain populations coming in? So there was this real need actually to be thinking about in local communities, the source of information around this emergency. Who was providing the reliable source of information about how it spread, how you can prevent its spread, and also, the affordable provision of PPE, of the protective equipment that you need. One of the things that came up was the cost of soap and the costs of masks. It impacted on family budgets.
But I think that's really interesting what you were talking about with digital care, because so I suppose this is what I would just finish with, because it brings us to another session that we're running on this conference as digital trade. And I think, here we are thinking that there are new opportunities to transact and to create, different opportunities for labour market participation, which might include women. But if we don't extend that notion of digital trade to digital care, and that balancing of the paid work and the unpaid work in the digital space, both in the digital space, becomes yet another challenge, and what responsibilities there are on wealthier countries to think about digital infrastructure and sharing that infrastructure in a way that doesn't require, that enables more capacity building, if you like, and a sharing of these resources. So thank you for that. I just wanted to give you the floor to answer or to offer any final thoughts before we close today.
Thank you. So thank you for that. I think what you said at the beginning, Jennifer, about one of the lessons of COVID-19 has been actually nationalistic responses and this desire to kind of protect your own. We've got to protect our own, and then we can think about what's happening outside. And I don't think we can remove that impulse. And I think, this is the wonderful thing about being a democracy, is that, politicians to some extent feel beholden to their populations. And so, they feel like they have to be conscious of vaccinate our population first, and then, so these are the sorts of things that are going to happen. But I think you're right in terms of what we know in our own national context is that protect our own populations first was not always effectively managed, and Bronwyn Carlson from Macquarie University has written some really insightful pieces for the conversation around the impact of this in Indigenous populations and the way in which we need to think about, where vaccine hesitancy stems from. And so I think, one of the first things that we need to recognise then is that actually thinking about a differentiated way of emergency response and also recovery in our own country could be really beneficial for our ability to be able to overcome and be stronger in the face of the next outbreak. But it also requires as well, I think, understanding and collecting experiences in other locations where there's been sometimes, weaker infrastructure, but a high dependence then on community networks and community engagements to try and facilitate access, overcome vaccine hesitancy and, be able to distribute consistent information about this pandemic, as well as protect local businesses and try and keep some kind of, consumer sector continuing. So I think there tends to be a little bit of a tendency to sometimes think about what we need to teach others. And I think one of the things that perhaps is really important, and I've learned this a lot from looking at the H5N1 outbreak, the avian influenza outbreak, right up to, successive outbreaks, is that actually there can be really amazing practices of innovation at the community level. It can come at a cost, right? Because you're requiring people to do extra additional work sometimes because there isn't always the infrastructure around them. But there's been amazing instigation of local community innovation that I think we need to go out and find now. And we need to understand how it was done. And we need to think about how to build those community platforms, because they've got, I think, a lot of insight that we're going to have to learn more about, actually, about how that kind of resilience, rapid, if you like, adjustment and then delivery was managed to try and bring populations with them through this crisis. And so I think that's something that we need to think a lot about as well, is not just the nationalism of the response, but also the way communities came together. And I think there's more out there than what we've heard about, actually. And that's something that I'm also learning from this research that I'm doing, that there was some real innovation there, and it needs to be talked about, and we need to learn from it.
Terrific. Well, thank you, Sarah, for joining us today. And we look forward to being able to access some more information via your website about the project and the other folks on the project. But in the meantime, from the Public Policy Institute and the Minister of Foreign Affairs and Trade, thank you for joining us today.
Thank you, my pleasure.